My name is Kaleb Abbott. I'm an optometrist and assistant professor at the University of Colorado School of Medicine, where I practice in our dry eye clinic. So I gave a talk about the discordance that we see between dry eye signs and dry eye symptoms. And I really think that this is probably the biggest challenge that optometrists and ophthalmologists face when we're trying to treat dry eye. The fact that what we see that is going on the eye oftentimes does not match the symptoms that our patients are feeling. So we went into a lot of the neural dysfunction that is surrounding that topic and to try to explain a lot of the reasons for this discordance. So I think we've all seen patients that come into our office and they say that they're having all these symptoms of pain and maybe burning and light sensitivity and grittiness, things like that. And then we take a look at the eye and we think this doesn't actually look that bad. There's only a little bit of corneal staining or maybe even no corneal staining. You know, their tear breakup time isn't too bad. Their blepharitis isn't bad. There's maybe only mild MGD, and we think, why is this patient so symptomatic? And I think a lot of times what we're seeing here is that this patient is experiencing a peripheral manifestation of a systemic condition. We really call this a central sensitization. So it's not really the dry eye that is causing their symptoms of eye discomfort, but rather it's something systemically that is driving their dry eye symptoms. These patients can also have something called neuropathic corneal pain or peripheral sensitization. So it actually can be a hypersensitivity of the corneal nerves themselves, and maybe that's occurring in the setting without a lot of corneal staining. So when we take a look at the eyes, we say it doesn't look that bad, but the patient is describing all of these symptoms of discomfort that's being generated just by hypersensitivity of those corneal nerves. This is so critical that optometrists and ophthalmologists understand this. We really have to try to get an idea of where is this pain originating from. Is it actually coming from the eye, or is it non-ocular in nature? And the best test that we have for this is just taking your bottle of proparacaine and asking the patient the amount of symptoms that they're having. Then you put a drop of proparacaine in both eyes, wait 2 minutes, and then reassess their symptoms. And we know that if their symptoms decrease a lot, maybe 50% or more, then we can confidently say this is really being driven by the corneal nerves themselves. So it could be actual dry eye, or it could be like a neuropathic corneal pain, but either way we know the symptoms are originating predominantly from the corneal nerves. If the patient says that their symptoms don't improve much at all with proparacaine instillation into the eyes, then we can confidently say that this is predominantly non-ocular in nature. This is not a problem with the eye. This is something that's happening further upstream along that trigeminal nerve, or maybe even in the pain processing centers of the brain. I think the risk in misdiagnosing a neuropathic ocular pain in these patients is less that the patient is going to progress and have something terrible happen to them. It just means that you're not going to accomplish a whole lot in your visits. It's going to be a waste of time for you and for the patient. It's going to be a waste of money probably for the patient, spending all these resources on prescription treatments and over-the-counters that may not be that effective. So what we really want to do is to try to get a better idea of what is causing these patients' symptoms of discomfort and whether or not it is truly dry eye or if it has neuropathic organisms, or maybe both. There's such a thing as neuropathic dry eye too. But trying to get an idea of why these patients are having those symptoms and where it's originating from, then we have to tailor our treatments accordingly based off what we find. On the flip end, we have neurotrophic keratitis. These are the patients that have more clinical signs, so maybe more corneal staining in what we would be considering kind of dry eye signs, but maybe they have less symptoms. It doesn't mean that they have no symptoms of dry eye, but they can be asymptomatic also. And so these patients, we have to understand that there's an underlying nerve problem happening here as well, where we're seeing that these patients aren't actually getting that sensory component that is being sent to the brain. So if we do corneal sensation testing in these patients, we lightly touch the cornea, maybe with a Q-tip or cotton wisp or dental floss, they'll report that they don't feel it as much as other patients do. And this is directly telling us that something is wrong with the corneal nerves. The corneal nerves are not relaying the information that they should be from the ocular surface to the brain. And we have to approach this fundamentally different than dry eye. We have to be thinking about this as a nerve problem rather than a dry eye problem.